Thank you, Nico, for giving us 3 different ways to think about frameworks. And you can see that they vary in terms of complexity and practicality. So the one that you landed on that's quite simple, that using a pipe mnemonic that is measurable and clear and actionable, that sort of simplicity is quite easy to see with your example. Tell us what your thoughts are about that second framework that you presented to us, where you really were focusing on the translation curve, and it's really about getting from research to practice. Do you have an example there about how those steps might be followed or utilized, and how well that's been taken up to connect research to practice?
Yeah, so the best example I can give you on that is actually my home department at Health Partners. So we actually designed the entire department according to this model, which came out of the work from Klaus Otto Scharmer at MIT, which really tried to figure out what do you need to make sure that there is sustainability built in, so that you can tie the practice solutions that you put out in the field, whether that's a community, whether that's a workplace, whether it's a school system, but let it be driven by data flowing through that model that allows you then to ask questions on the back end. Mm-hmm. So in a sense, it is both a feed forward and a feedback mechanism that allows you to always be ahead and thinking forward, but making sure that you close the loop on the back end to be able to report out progress and see where barriers or challenges come up that need to be addressed. In our work, it made sense to start with what we know works. So you start on the research side. The systematic reviews are a great example of understanding what works, because it is a systematic review of all the available research. But then you need to add to that the reality of the practice, the reality of the real world. And so you cannot limit yourself to looking only at health literature, for example. You need to add other literatures in there: business, marketing, management, and engineering, architecture, different fields that have their own literatures that doesn't necessarily show up in a systematic review on obesity prevention or something like that. So you add those all together in that translation curve and start to really think about what can a solution look like if you brought all these pieces together. This is why I said earlier, when you think about effect size as an example, the vast majority of obesity interventions have very small effect size. So what would you pick? It's very difficult to sort of land on one programmatic solution. So out of all the literature, when you put all the pieces together, what we're finding is that really multi-component, multi-level, multi-stakeholder, multi-sectoral, multi, that's really ends up what's working. So that means that you've got to bring those stakeholders to the table. You've got to have processes in place to bring and keep stakeholders at the table. All of that is getting away from that data point coming out of a systematic review from the health literature, way out there. So the linkage, and this is where the 4 S's show up with the pipe metric, it comes out of practice rather than research to test the framework that you put out in the field. So we've really tried to sort of bring those two together, and when you bring all of that work together, that's how you end up with that model, that second model, that practice and research connected. Because once you go out in the field, you still need evaluation models that can allow you to get that data and feedback, which is the total quality management, which is the TQM, the PDSA cycles, the action research, particularly in the educational setting. There is just no room for a randomized controlled trial in a workplace, for example. Very difficult to do. Mm-hmm. So that's kind of how I would characterize that.
Well, congratulations. That sounds very complex, but clearly working in terms of implementation. My last question for you is, what do you think when you look at how to create a framework that is actionable, that is really useful and practical, what should those successful ingredients include?
Well, first of all, I think it should be simple. Mm-hmm. So in fact, the example of the pipe metric is a simple approach, and it came completely out of practice. It's what practitioners can do, They don't need additional expertise. So it has to be low resource, simple, and it's, sort of run it through the lens of sense making. Does it make sense, just intrinsically? And then of course it's the continuing it so that it doesn't die, supporting it that doesn't die. So can we apply it to different situations? Can we get practitioners to pick it up and run with it and see if it works in their own setting?
Thank you.
Any other questions? I was actually going to ask a related question. So when you look across all the frameworks, in addition to simplicity, do you see any other attributes that these frameworks share? Or what's common? I think simplicity is one of them, but any others?
Yeah, I think, well, so it's an important question because from a framework creation perspective, you need to have some principles. Yeah. Simplicity is one, but at the same time, it cannot be more simple than it could still work. So, and particularly recognizing the obesity situation, which is complex. You can't go that simple to lose all of it. And depending where you sit, for example, if we take what we talked about this morning on prevalence, what's the framework for a national obesity prevalence surveillance system compared to making sure that that data can flow down all the way to local or regional settings, where oftentimes you have huge data gaps. You can't go so simple that it doesn't work anymore. So I would have to think about that a little bit more in terms of what are the principles that cut across all of these. But I would say that simplicity, as simple as possible, would be the one on my mind.
Sounds like there's another question.
Yeah, this is interesting because it takes us into sort of an action-oriented, into the program, actually into Health Partners unit somewhere. But I'm struggling a little bit with, so the NHANES and measurement is on surveillance, and then we have BRFIS as kind of local program planning, and now your measurement for action. So I'm trying to sort of knit those three together, and I don't know if you could do that for me.
Well, so I think Laura presented this morning the idea that really you have, when you think about the data that is collected, it's multiple cross-sectional views of where you're at. And so what happens in between those multiple cross-sectional views is action to try to change everybody in the community so that the next cross-sectional view, which isn't the same people, actually can pick up that change. So what change is there, is going on, if you will, that can actually explain in sufficient detail so that it is plausible that whatever we invested in fact is generating an effect large enough to pick it up with those cross-sectional views. And I think that's the intent of that framework, is to connect those dots in a way that at least at the level that you're working, you can pick it up.
And I was also just going to ask, outside of your institution, are you aware of other stakeholders who are sort of using these frameworks? I know that some of the work was done at MIT, and you guys have adopted it.
Yeah, so I would say the adoption of the MIT model, Sharma's model, is global.
Okay.
That is an enormous undertaking, and that's been well documented. Okay. The 4 S's and the pipe metric, for example, we apply that to multiple settings. So we particularly apply it to our work with companies and worksite setting, because that's where you can define the population really, really nicely. So beyond that, the model hasn't, as far as I can tell, hasn't been used. We do have a paper that will be coming out that is looking at the diabetes prevention program literature. to see through the lens of real-world applications how this pipe metric actually performs when you apply it to the real-world DPP translations. And looking at that, I can tell you there was not a single article in the literature that allowed us to calculate this impact metric, but there are many that hit like 2 or 3 of these coefficients.
Okay.
So it is, I think, possible to start thinking this way, to really try to connect the practical application to what comes out of the literature as a, but it's not there yet. There are huge gaps.
Another question.
I just have one question. You mentioned about prevalence and trends, and you introduced incidence in obesity. So for the triangulation, could you elaborate that a little bit?
Yeah, I think incidence will give you an idea of where the hotspots are, if you will, in terms of what's going on at that time. So if you see incidence change in a certain population, you may have been effective in intervening earlier, but it's going up in another area. You may, on the whole, not see a change in overall prevalence. Mm-hmm. So it would give you another view of the problem.
Mm-hmm. Okay.
All right. Thank you very much.
Thank you.